There's a new ACEP news alert available now. Listen to Dr. Rob Anderson, co-founder of Merit Health, explain why every emergency physician should take the new and anonymous ACEP Emergency Medicine Compensation Survey. Search ACEP News Alert in this podcast player to listen. Follow the channel to get every update on your mobile device as it happens.
All right, Ryan Stanton here. We're with ACEP Frontline, and you know Jim, Big Jim Neuenschwander. He's the one that if you listen to the very end of the podcast, you'll hear him poking at the actual music that we use. And then Dr. Steve Anderson, who's somebody I've worked with for a long time through comms, through the American College of Emergency Physicians, but also here today because of the passion with regard to the substance use disorders, opioid use disorders, and that transition now into recovery, which is the most important piece of this. And I've always said since being from Kentucky, talking about the opioid epidemic for decades now, 2.5 at least for me talking about it, that the best thing would be for the recovery would be those that have walked the walk, talked the talk, and now are on the other side and can help others along the path. So let's dive right in with everything. Steve is an integral role with the Naloxone Project. With Big Jim here, he's doing his piece with the Ohio side of it as well. And let's talk about where things are, the evolution, and how we are where we are right now with substance use disorder, with opioid use disorder, and now recovery in this project.
But okay, let's talk about ACEP. ACEP's been involved in substance use disorder for decades and decades. You know, opium was first used medicinally in the Stone Age, which was even before I started practice. But it wasn't really used recreationally that we know of until the 15th century in China. But in 2010, the most common prescription written in America was for hydrocodone. And ACEP realized that we were part of the vectors in the overdose epidemic that started at about the beginning of this century. The pathway of overdoses that were climbing so rapidly correlated with the number of prescriptions we were writing. And so ACEP actually stepped in and did a lot of things. ACEP created an emergency department information exchange to highlight those people at risk. It helped push us towards creating PDMPs. Probably most importantly is we founded a section in the college for pain management and addiction care. And the important thing about that section, it was not just about how to say no of addiction care. It was really how to treat pain the best way possible, which we still keep at one of our highest levels. But unfortunately, even though we helped to slow that rise, then fentanyl entered the whole situation, and it changed the whole game plan. Now we're talking about not just going up steeply, but logarithmically for overdose deaths in America. And so ACEP knew that it was time to step in with even new ideas. They created an accreditation process for hospitals, particularly around departments, for policies, procedures, both for the best pain management as well as how to begin the treatment for substance use disorder, instituting buprenorphine induction, how to integrate peer navigators, because as I like to say, having someone that's walked the path with lived experience is integral. And the quote I always bring up is, anything done to us without us isn't for us. So it's why we have people like Jim on the board of directors of the Naloxone Project, because we've taken the attitude that we need people alive. And prescriptions are only filled at a 2% rate for naloxone. So we want it handed to people who are at risk when they leave our departments or when they leave OB departments or anywhere else. So we've created ways that hospitals and departments in particular can identify those individuals and hand them the naloxone with the message of your life matters to us. We care. This is our gift to you because we want you alive and we want you to know you can come back to us if you have any issues around substance use disorder that we can help with. And the Naloxone Project has been really instrumental, which I am blessed to be chair of the board and have Jim on the board with me. But solving this issue is multi-level. It's not just engaging our peers, but it's engaging legislators. It's changing laws and policy, which Jim has been a leader on at the state level. And we're working federally as well to try and change that.
We've, interestingly, you've got the naloxone actually hanging from your vest right now, and actually most places, last few conferences that we've had with ACEP, we've had the opportunity partnering with the Naloxone Project and others to actually give out naloxone. In fact, that exact same one with the keychain is, I have 2 of those in the door of my Forerunner that stays there all the time, along with my tourniquet that's always there as well. Because interestingly, we actually had our governor a few years ago had somebody overdose and pass out in the street in front of his motorcade, and they got out and actually administered Narcan in the middle of the street in downtown Lexington. So, it's important. This is an opportunity that everybody out there can actually save a life. You don't have to have an MD or DO after your name. This is the opportunity that you can save a life, and making sure that it is there, because you can't recover somebody who's no longer with us. And that is exactly what we're trying to do, is we're trying to build that bridge and get the patient, get that person, get that human. I think that's the most important thing, is to get that human back, to get their life back. And it's not a one-day immediate thing. So Jim, we usually talk about a lot of other things, usually making fun of Ohio State, but you guys have been successful, and that makes it difficult for me now.
Yes.
But tell me about your role kind of coming into the Naloxone Project, what it means for you in Ohio. Because if there's any place that represents the opioid epidemic, it is my state of Kentucky and your state of Ohio, especially if you've read any of the Sam Quinones books that talk about Portsmouth, Ohio, which is on our border. We've got a couple of interviews. If you haven't heard those, check back into our historical. We've got both episodes of both of his books, great books, and great interviews with him. But talk about your journey into this.
Absolutely, and I think, again, those books are fantastic if you ever get a chance to read those. And I practice in Ohio and have lived through what this epidemic has done to our state. We were number 2 in the nation for years, which, we love when our football team is ranked number 2. We'd like them to be number 1, but we don't want to be number 2 in opioid overdose deaths. So we have taken a very strong movement towards decreasing that number of overdoses. And as Steve pointed out, if you look at the number of naloxone prescriptions that are actually filled, it's less than 2% in most states. Mm-hmm. So we cannot just say, go to Walmart or CVS or wherever it is you're getting your prescription filled and think that we're actually making any kind of impact. You're not going to take a mind that's been hijacked by addiction and say, here's a prescription that may cost you 10, 20, 30, 40, 50 bucks and could save your life. They're going to take that money and put it towards drugs every single time, Ryan. So what we have done instead is said, here is a medication. It won't be the one that saves your life, but you're going to know someone else that it will. And the impact of saying that your life and the lives of others like you really matter has made a huge impact. And we have slid out of number 2, depending on where you're looking at the rankings that I've looked at them recently. We are probably around 7 or 8 nationally, and we are looking to quickly get out of the top 10 and be able to demonstrate that this impact of giving naloxone, caring about people. And you're right, saying if you're alive, we can help you. We can't do anything for you if you're not.
There are departments that actually do this all over the country.
Right.
But to create a system that's sustainable, you really need to pass legislation. You really need to have that in order. And that's what Jim did in Ohio. Jim passed legislation that basically says this is the right thing to do. We need to do it.
With a lot of help, as a matter of fact, from ACEP, was very supportive. Michael McCrae, Jason Kolb, Dave Seaberg, many helped jump in and help us get to a place where, we just passed the law it was this spring, that if there is a time whenever the state grants, and they're coming, Ryan, I mean, you know that, is that the states are going to focus on other issues and giving free naloxone out. So what we passed was legislation that said that we can actually bill the private insurers or Medicaid for the naloxone, and actually then the hospitals can be reimbursed. So we're looking at different mechanisms and ways to be able to get naloxone to those people most in need.
Interestingly, that area where we are right now has had the largest drop in opioid associated or substance overdose deaths. But it's important. There's been a lot of work. We've got the program. It was the ALTO program that was all of the emergency departments in the Commonwealth of Kentucky, and then we actually translated that into the Bridge program, which is now in probably about a third of all the hospitals across the Commonwealth. And it really has been a lot of work. And one thing we uncovered was that Medicaid would cover naloxone as long as you didn't overdose more than once a month. Because I filled one for a person who came in, and we'd send him down to our pharmacy to pick it up because I wanted to make sure he had it before they left the department. So I had them go down. They said, we can't fill it because they filled one 21 days ago. And I was like, well, here's what it is. And interestingly, what I ended up doing, probably shouldn't, is there was one of our ambulances was out there, and I grabbed one. And made sure he had one before he left.
I'm glad you did that.
And it was about the key is for substance recovery is they do have to be there. That's key. But also is tearing down as many of the barriers. That's what we found for the 20 years of the attempts to get this going, or not this going, but any of the recovery going, was the fact that there was just speed bump after hurdle, and every one of those was an opportunity for us to lose that person.
The biggest battle we still fight is stigma.
Absolutely.
The idea that this is a moral weakness, it's not a disease. It's a disease. It's like diabetes, it's like COPD. There are relapses, there are problems that people have along the road, but we now have the ability to offer support. We have the way to resuscitate you and give you a second chance. We have the way to start medication-assisted help along the way, tie you into bridge programs so you can get follow-up and all that. What I really want to point out, because this is our interest, is that everybody deserves a second chance. We think of naloxone as the gateway drug to recovery. We have that rare opportunity in the department to address somebody at that critical moment and say, your life does matter. And we at the Naloxone Project, we want to be the resource for any questions that anyone has along how to institute the program, to dispense it from your department. Education, how to get it paid for, all those sort of issues. So any questions at all, please go to our website, naloxoneproject.org, to learn more about that particular incident.
And we have the education in different languages as well. So, one of the projects we had at a community hospital I was working at, Ryan, was we initiated buprenorphine. And what we demonstrated was over the next year for patients that had, similar age, sex, chief complaint matched complaints for the group that we started on the buprenorphine versus a group we did not. The group that had buprenorphine started came back to the emergency department 33% less and were 66% less likely to be admitted to the hospital over the next year. And so our chairman, in his wonderful way of looking at it, says, hey, listen, most of these people, after we get them started in recovery, get jobs. They're reunited with their family. They're paying taxes and child support. We see massive changes in these individuals. And he said, even if you don't see them as human beings, think of them as at least these dirtbags aren't coming back to the emergency department as often. And I thought, well, it's not the way you really want to think about it, but at the same time, you can't lose by investing in somebody's recovery. You can't lose by getting them on a road, because they're going to become better people. They're going to become better members of society, and they're going to come back less frequently. And when I see these patients, and I have seen them, I had somebody not long ago that every time she comes to the emergency department, she's got flank pain and blood in her urine. You have to take her seriously, right? I think she's pricking her finger, and she admitted this later, because when I saw her and she had come back in recovery, bright eyes, clear skin, and I was like, what's going on? She goes, I'm in recovery. I said, this is crazy. Well, I didn't say this is crazy, but I mean, this is what I'm thinking. She said, please don't give me any narcotics. Toradol will be fine. I really might have a kidney stone this time. And we just sat and talked. It was one of the greatest experiences of my whole career. It was like, and she said, I'm going to meetings. I have a sponsor. I'm back with my kids. She didn't have custody at that time because, that's a process, right? It doesn't happen overnight. And yet she was this human being who we had invested in, and now her life was better. And my whole experience with her went from being the heart sink, seeing, oh my gosh, she's here in my section, hematuria, flank pain, gosh darn it, now, to a wonderful experience of seeing somebody's life transformed. And my life was transformed too.
What might be used to be your worst patient, the chart you didn't want to pick up, can now be the most rewarding. And you know what? We're making a difference, Ryan. 3 years ago, 111,000 people died of overdose in America. And then this last year, less than 70,000. That's not a drop of 1 or 2% overdose death rate in America. That's a drop of 30%. And everybody points to two major things. One is decreasing fentanyl in our communities, which is mixed in almost everything that's on the street now. But the other is access to naloxone. People deserve a second chance.
I completely agree with that. And you know, I always tell people when they try to write off as a different type of human being, is the fact that nobody in 7th grade said, I want to be a slave to a substance. And so these were people who had dreams, who wanted to be a doctor, lawyer, firefighter, teacher, whatever. And what we're doing is we're giving them their opportunity, that second chance to get back to it again. And as we wrap up today, because I have to get you back to the meetings because you are actually educating more people downstairs, I want to get your closing thoughts, but then also, you know, Steve, you mentioned it was okay, like your invested interest, why this is not just your calling as a physician, but also a deeper calling.
I have a passion for this that I will never give up. It's based on a hairstylist I had by the name of Casey. Casey was a wonderful individual. You know, if you've ever had your hair cut, you know, a hairstylist is one part artist, one part a business person, and one part psychiatrist, because we tell them everything. And Casey was really good at it. She was also an adrenaline junkie. She rappelled down waterfalls. She skied Black Diamond Hills. Really an exciting person to be around, but she met the wrong person at the wrong time. And in Casey's words, she'll tell you that the first time somebody said, here, you should smoke this, and she smoked heroin, she said, I knew I was addicted. She fought that addiction for several years. She was in successful sober living, but the nature of the disease is relapses. And when you haven't been using for a while and you relapse with fentanyl, the naloxone wasn't there when Casey needed it. And Casey passed away a couple of years ago. And Casey wasn't just my hairstylist. Casey was my daughter. And so my goal in life is to make sure that no other Casey in the world doesn't have naloxone available if they need it for a second chance.
So if you need any motivation, it's Casey, because just think of Casey as the current 70,000 people we're going to lose as somebody's son or daughter, husband, wife, father, mother, whatever it may be. When we got into emergency medicine, almost all of us said we wanted to help people. In our personal statements, we want to help people. We want to save lives. And we're searching for that every single time we go into an emergency department. And it's sitting there right in front of us. It is that person that you care about, that you give hope, that you give them an opportunity, that you take down a hurdle, you patch a hole in the bridge, and you get them the help they need. We can't save every single one, but we can save one. As my preacher said, you can't change the world, but you can change somebody's world. And that's your opportunity you have right there. Give us the website once again and contact information for the Naloxone Project.
Naloxoneproject.org. You can learn about that, plus the other programs we do, including trying to get education into the schools, and naloxone into schools, getting it to pregnant women, and other things. But probably most specific to this audience is our HANDS bill, which has federal legislation, and the kind of bill that Jim passed in Ohio, which is hospitals as naloxone distribution sites.
I appreciate you both coming up, taking a little time to join us up here in the Blue Sky Room here at our Partner Collaborative. And thank you so much.
Honored to be here. Thank you.
Thank you, Ryan.
As for me, contact me, rstanton@acep.org, rstanton@acep.org. Please subscribe to the podcast on whatever your favorite player is. Share it with your friends, neighbors, colleagues. Give us a 5-star review, please. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
For If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.